World Cup.
Yeah.
Okay, I will tell you the result after this. Okay.
Yeah,
Okay,
yeah.
I'll allow the time for you, Dr. Alex.
Thank you. No problem.
Yep.
Have a nice time. Enjoy. Bye bye. Okay. Let me share my slides. Good afternoon, everybody. I think all are from Indonesia, I guess. So my topic of discussion for today is that it's about patient behavior in the digital area, specifically with reference to pharmacist roles in influencing patient behavior in the digital era. So my outline of presentation is I will talk a little bit about me, introduction and overview about the topic, and then I will try to explain on each of the topics: patient behavior, digital health, and digital pharmacists in patient care. I guess if in case if you haven't met before in some meetings, this is Alamaya from, my background is actually from Ethiopia. I moved to Australia in 2014 for my PhD. My professional background is Bachelor in Pharmacy with further specialization in clinical pharmacy. I'm currently a research fellow at Deakin University. So my research interest is more of focusing on medication safety, quality of medicines, health services, and evidence-based healthcare. So to begin with, it's the topic is a general one. So I was trying to look at the connectedness between patient behavior, digital health, and pharmacist roles. So it looks very broad topic actually, but I will try to discuss a little bit about patient behavior, digital health, and pharmacist roles, so that we can have some sense of all these common themes finally. So this is a patient case. I wonder if you're able to read, and I have a couple of questions that derived from this patient case. So have a read on this patient case, and you will answer questions that follow this case. Can you have maybe 2 minutes reading for this? And you can, you can pop up the answers on the chat box so that I understand the level of your understanding on some of the questions. So this is Mr. V, who is an 85-year-old man who comes to hospital, for example, for his 6 months visit. That's for refill. He has past medical history of congestive heart failure, atrial fibrillation, diabetes mellitus, benign prostatic hypertrophy, and gout. He has been supplied with 19-day supply with 3 weeks remaining. So he's, during the encounter, he's saying, I hate taking the water pill and blood thinner. I am on so many medications that's difficult to remember them all. I've skipped them from taking for the last 1 week. So these patient's medications are this one. It's around 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Around 10 medicines have been prescribed. So based on this patient's case, Mr. I don't know here, sorry. Have you got time to read all the information from the patient? If not, let me know. So Mr. V's non-adherence decision is, what is the answer here? Do you need more time to read the case?
C maybe.
Okay, good. Okay, let me show you again. These are, yeah, don't worry about the number of medications. The patient is taking 10 medicines. But, you know, he complained about taking the water pill and the blood thinner. The water pill is this one, frutamide, whereas the blood thinner is warfarin. So he complained about the water pill and blood thinner. He don't like them. One of the things is that because he's taking too many medications and he skipped taking these medicines for the last 1 week. This is the case. So based on this, Mr. V's non-adherence decision is intentional because of problems with safety of water pill and blood thinner. B, unintentional as far as we don't have objective data to confirm. C, intentional because of problems in medication burden and forgetfulness. D, A, and C. So you can pop up your answer here so that we can have a common understanding of the question itself. What do you think? First, let's differentiate whether it's intentional or unintentional. Is it intentional or unintentional? It's definitely intentional, is it? Because the patient knows why he discontinues the medicines. He knows very well. So let's go to choice A and C. So we should choose whether the right choice is A or C. So which one? Or D maybe as well. Okay. So which one is maybe the better option? Let's make it interactive if possible. Otherwise, I will try to answer them and we'll go.
Sorry, Mr. I think it's C because the intentional from the
Yep.
The A option is not about the safety, but the patient is hate just to eat.
Yeah, exactly.
To the medication, not about the safety.
Yeah, exactly. You're right. Yeah, it's intentional because of problems in medication burden and forgetfulness. That's the right answer. What about 2? Then let's go to question number 2. Mr. V's non-adherence decision is only right when the risk of taking the medicine outweighs its benefit. It can't be right to stop taking whatsoever, only when instructed to do so by a family. The patient is severely unwell. So when it will be right to stop medicines intentionally? That's the question. So the better option maybe? Is it safe to take a medicine which is have a high risk, for example, or else if the patient thinks that the bleeding is due to warfarin, for example, if the patient has a bleeding and he assumes that the bleeding is because of warfarin, so in that way, if he stop or she stop, is that right or not? So maybe if anybody else who can't answer, I can go straight. So in this case, if the patient's, the medicine safety profile is very risky, you don't need to take a medicine which is very risky. So in that way, it may be right. Non-adherence decisions are not always unnecessary. There may be times where it may be necessary. So, because this is not it's about behavior, it's about safety issue. In safety issue, non-adherence may be it's not behavior related. It's about safety related. If I'm clear, most non-adherence decisions are intentional. True or false? Pop up in your chat. You can say A or B. Pop up. Let's make it active. Say A or B.
Maybe A, maybe B.
Yes, it's right. Most non-adherence decisions are intentional. Behavior plays major role in unintentional medication adherence. What about this one? A or B? True or false?
True.
True. How behavior plays in unintentional. It's unintentional. That means the patient don't know whether he skipped the medicines or not. He don't know. The non-adherence, it's not about decision, but because of some system problems, maybe, for example, or because of problems in identifying, maybe. So that's not behavior related, actually. It's because of system related, maybe, or yeah, it's most likely system related. Maybe, communication of medicines from physician to pharmacist to the patient, maybe. So because of some discontinuity, for example, from the healthcare perspective, that's not behavior related. So behavior usually plays a major role in intentional non-adherence decisions. Which of the following questions will help you to uncover barriers to adherence and develop a tailored intervention plan for Mr. V? Which question is better to identify the barriers? Which one is better? Which question is good to elicit barriers to adherence?
B, maybe.
How about using a pill organizer to help you organize your medication? What about A? Well, why do you think you are having difficulty remembering? Because because it elicits the patients. Why? It's asking the reason. It's a reason.
Find the problem.
It's the reason out, so that you are identifying the reasons for barriers. So this may be better than how about is kind of yes or no or something. This one that it may not have so much reasons to explain. Knowledge is a guarantee for taking goal-directed behavior change. True or false? Take the example of smoking, for example. A person smokes. For example, healthcare professional smokes. So in this case, is knowledge a guarantee for taking goal-directed behavior change?
So it falls.
False. Yeah, it's right. 30% of people with chronic conditions are non-adherent to their medicines at any given time. How many percent? Just close, approximate numbers, approximate percentage. Maybe closer to maybe 50%. Is close to 50% of people with chronic conditions are non-adherent. Anyways, we'll discuss this one in the remaining slides. Digital technology are now replacing the role of pharmacists, and the future of pharmacies, the role of the future pharmacist role is at stake. True or false?
Not all. It's false.
False. I think false.
False.
Yeah.
It's false.
It's false. It's false. You are right. So, okay. Sorry. So maybe these are discussion questions. We have the Mr. V's case. Mr. V's case was that he had taking blood thinners and water pills because of this, and because of many medicines he's taking, he stopped taking these two medicines, water pill and blood thinners. So what behaviors do you know to address here? What's the behavior of Mr. V to stop taking the medicine? Okay, keep this question in your mind so that we'll come back later after we discuss the slides, so that we'll have some brief discussion about this one. So let's go to let's begin with the discussion of behavior and health. So what do you know about behavior and health? Do you think that behavior have an influence on health, disease, and taking some measures to prevent health? Is there any interrelation between behavior and health or no? So yeah, this diagram shows that there's an interlink between behavior and health. You know, there's physical health, there's psychological health. So actually, these are dual pathways because one affects the other. And for example, in terms of psychological factors, you know, a person having some stressors, psychological stressors might affect their physical health. These are direct impact of psychological factors on health. But at the same time, you know, without a stressor, even without stressor, human behavior can guide our health. You know, so it does not need to have some psychological problems or stressors to affect our physical health. But at the same time, even with health, with some psychological health, we can have a behavioral problems to act upon our physical health. So in that way, this is a hidden factor. That is health behavior. Health behavior, it's an action. Anyways, we'll define this one later. It's an action. So with this in mind, health behavior can have an influence on physical health, at the same time on our psychological health. This is very important thing because we're dealing about patient behavior. So patient behavior can be influenced by a number of factors. For example, can you see this one? Some psychological factors can directly influence, for example, our cardiovascular health, so that it may bring an increase in hypertension. You know, it may result in arterial constriction or bronchoconstriction. So it may have a direct impact, or else they will come through some modifiable factors like, for example, elevated BMI or an increase in hypertension, or lack of activity, for example, which have an influence on physical health later in our life, for example. So here, the point is, psychological factors can directly impact our health. This is the point of this diagram. So how many percentage of the diseases are caused by behavior? Do you expect that up to 5% of the cause of death is related to behavior? Have you think before? Specifically with chronic disease, yeah, with non-communicable disease, behavior can result in 50% of the disease, like, you know, with respect to mental health problems by itself, cardiovascular disease by itself, because there are some connections between central nervous system and all these non-communicable diseases. So in that way, that's one thing. The other thing is the behavior itself, you know, like taking action on preventing from cardiovascular risk factors, diabetes mellitus. So we can talk about two things here. One is to prevent physical health. Another is to prevent from psychosocial stressors. So in both ways, it can have an influence. Behavior have a great impact on the cause of death. So defining behavior is a general term to mean that it is action or reactions of an individual to a situation that can be conscious or unconscious, voluntary or involuntary. When behavior is applied to human health, we call it human behavior. I mean health behavior. And it's usually complex and it's difficult, understandable. And it's behavior is also very fluctuated, is it? Yeah, it's very fluctuated. It varies from time to time. Leave it for any patient or in some in a person with some stressful situation, or in a patient with some disease. Even in normal individuals, in healthy individuals, health behavior is affected by a number of factors, and it may vary from time to time. Health behavior, like any other behavior, is motivated by stimulus. Yeah, motivated by stimulus. Yeah, it's about motivation. It may be internal or external. Yeah, it's both ways. Motivation which leads to health influencing behavior, may also not be related to her health per se. Yeah, this means that motivation can be related to health or may not be related to health. So it depends. It depends. And it's dynamic and not static, as I've said before. So types of health behavior. Health behavior can be defined as direct behavior or related behavior. Direct behavior means we have really a specific health behavior that should be targeted. Whereas health-related behavior means it may not be, we don't have any specific health behavior in mind, but we need this behavior to target some factors holistically. Types of health-related behavior: preventive health care. Can you give me some example about this one? Preventive health behavior. Preventive health behavior. Example. For example, taking COVID vaccines, isn't it? Taking COVID vaccines for prevention of COVID is a preventive health behavior. Or taking a child for immunization, that's a preventive health behavior. Or else taking, for example, exercising, to prevent some cardiovascular disorders.
Taking vitamin, maybe, yeah. Vitamin in the rainy season. taking vitamin C, maybe.
Yep. That's also another example. So there are many preventive therapies. So that can be included here. It's preventive health behavior. Illness behavior. Illness behavior means the person develops some symptoms, which so we don't have a definitive illness here. I mean, there is no a definitive diagnosis, but there are some kinds of signs and symptoms. So in this case, a patient or an individual may take action. So in that case, that we call it illness behavior. For example, it's common in taking some OTC medicines. Yeah, for example, taking cough medicines if you experience some coughing, or if experience headache, so you'll take some paracetamol. So that's the illness behavior. There's some symptoms, but that's not definitive diagnosis. In that case, you may take some medicine. So that's illness behavior. Sick role behavior. What's the difference from illness behavior? Sick role behavior. The difference compared to illness behavior. Here, there's diagnosis. There's diagnosis. It's known. The disease is known. So in this way, a person may take action. For example, taking some medicines for malaria, or taking medicines for some cardiovascular disorders. So sick role behavior. Can you mention some examples of factors that determine human behavior, specifically related to health? What kinds of determinants are available that can affect health behavior? Just specific examples. Okay, maybe let's go one by one so that that may be clear. For example, background factors. Background factors means characteristics that define the context in which the people live their lives. That means, the way we look diseases maybe differ from area to area. Some diseases may present in some area, some diseases may not be available in other areas. So the way we look diseases, or the way we look, for example, lifestyle. Our lifestyle also depends from culture to culture, environment to environment. So actually, there's also social component here, actually, don't forget. But to mean that background factors can have an influence on health behavior. Stable factors, these stable factors are our personality, the way we look as a person, as an individual, the way we look, the disease, or the way we seek health, it differs from person to person. So it's also it's determined by personality factors as well. Individual differences or personality in psychology can contribute to health behavior. So these factors are usually stable factors. We call them stable factors. Other is social factors, social connectedness in the immediate environment. These can also have a factor, is a determinant factor. Situational factors depends on the situations. Depending on the situations, our human health behavior can also be influenced. So I'm discussing this because human behavior can be affected by a number of factors. So when designing interventions related to behavior, we need to target a number of factors into consideration in designing interventions to be successful, because there's no any single behavioral determinant that can affect a person's health. So this is very important in designing interventions, specifically on behavior. So what is the relationship between knowledge and behavior? As I've said before, there's a relationship, yeah. But the relationship have, there's a number of steps to pass through before you act upon on some target. For example, doing some exercise, to prevent cardiovascular risk, for example. So, but to reach to there, you should have a number of things. For example, how to do the exercise, what's the links between lifestyle change and development of cardiovascular disorders. So there's a number of steps before acting on a specific action. So that's why I put this diagram to show that there's a link between knowledge and behavior, but there are a number of steps to pass through to act upon on a specific targeted behavior. In some cases, knowledge may be sufficient to elicit change in behavior, but in other cases, it may be neither necessary nor sufficient. Yeah, usually knowledge is important. It's important. And the available knowledge may be sufficient to achieve a behavior, but not always. Sometimes people may have deficit in knowledge to act on some behavior. It should not be assumed that individuals are always knowledgeable about an appropriate health behavior. But neither should it be assumed that knowledge will guarantee change in behavior. This is the one I talked before. Having knowledge does not mean that it always results in a change in behavior. As I've said, there are a number of steps to pass through to come to a behavioral change. Where knowledge is deemed important, this should be expressed in terms that are salient to the target audience. The transfer of knowledge into action is depend on a range of factors, both internal and external, including values, attitudes, and beliefs. Yeah, I will try to discuss this one later, because between knowledge and behavior, there's attitude, beliefs, and values. So that has also an important impact. So for most individuals, the translation of knowledge into behavior requires the development of specific skills. Can you give some examples? For example, to act upon some behavior, what kinds of knowledge do you need? For example, to quit smoking, what kinds of process should we pass through, for example?
Avoid the people smoke, maybe.
Okay, good.
And take a candy when you remember about the smoke.
Yeah, I remember. Okay, that's good.
And also, it's the most important is exercise.
Exercise, just whenever they think about, for example,
to forget about the smoke.
Yes, to forget the smoke. There should be some distraction. For example, this is actually strategies to distract from that behavior. So yes, this can be strategies that also part of the knowledge, the whole sum of knowledge. Yep. So in between knowledge and behavior, there are attitudes, values, which are important to have, that specific behavioral change. An individual's attitude to a specific action and their intention to adopt is influenced by beliefs, motivation, which comes from the person's internal factor, attitudes, and drives. Usually there are so many kinds of studies which deal on knowledge, attitude, practice, because they are interrelated to each other. Yeah, because without having the required attitude, you can't bring behavioral change. Actually, it's not always. It's not always, because there are some behavior changes that may be brought without prior knowledge or prior awareness of some attitudes. It's not always, but usually the usual practice is that having the required knowledge, having the required attitude can bring the required behavioral change. So this behavioral change can be brought about by your strong beliefs, your strong motivation, which is usually internal. It's also affected by norms, social norms, outside your internal factor. It can also be affected by social norms. Yeah, that's belief and values are very important for to bring the necessary attitude. Okay, attitudes have different components. Yeah, that's that I told you. Belief is there, feeling, and behavioral act. That behavioral act is actually is following the belief and the feeling, because this behavioral act it's closer step to bring behavioral change. So it's closer to the behavioral action. So values and attitudes help to explain the knowledge action gap. That's what I told you. There's knowledge, there's practice. Practice is what I mean is the behavior change intervention, or the behavior change practice. So between this is the values and attitudes. Attitudes involves beliefs, motivation, internal feeling. These all things come together to bring the behavior change. There is no clear or linear progression from attitudes to behavioral change. Yep, this is what I talked, because some behaviors may acted upon without prior attitude, or So there is no any clear or linear link or progression, but still having the required knowledge, attitude are important for behavioral change. But equally important, behavioral change may precede and influence attitudes. Yeah, it may be in both directions. Behavior change may precede attitude. Attitude may precede behavioral change. Usually, attitude precedes behavioral change, but at times, behavioral change may precede attitude. So it may be two-directional, but in most cases, attitude precedes behavior change. So models of behavior change. Why we talking about models? Why we need models of behavior change? Oh, sorry. What do you think? Why do we need models for behavior change? It's because there is no any single, as I talked before, there is no any single behavior which helps to attain some behavioral, some attainment of some goal, which is behavior related. There are a number of factors that can influence health behavior. So these all factors should be addressed. So these factors are developed through models. Is that clear? So models are very important because they address a number of behavioral determinants important to act upon a specific action. So these social cognition theories are very important because they try to link the relationship between these social cognitions, knowledge, beliefs, attitude, goals, and behavior. So they try to link both. knowledge is there, attitude is there, goals is there, values are there. So with the behavior, so they try to link these two together. So they're very important because they're important in behavioral intervention development. Do you know some examples of cognition theories before? Have you learned from health promotion or health education? Have you taken such a course? Health education or health promotion? If I'm correct, you are a graduate student. I hope you have discussed or have learned health education or health promotion in your undergrad studies, if not in your master's. So these are some examples anyways. These are some examples of health theories for changing behavior. Health belief model is one of the thing. The other is theory of reasoned action. The other is trans-theoretical model. So have you heard of any of these models before? Okay. Health belief model. Health belief model, there are two factors that will be considered in health belief model. The first is the person should, the person should feel the disease. The person should have some know-how about the disease to take some action. The health belief model is that the person should be aware of the disease, or the person should have aware of the disease severity maybe, or the susceptibility to the disease itself, or he or she should have some awareness about the disease. That's the first thing. So the second thing in the health belief model is that the person will take some action because of this thing. The person will take some action. So this action may be preventive as therapy or illness behavior, whatever the one I said before, or sick role. So two things are here. The patient should perceive there's some disease or threats to disease, and then he or she will take some action. This is the health belief model. This is the detailed diagram about the health belief model. The first is, as I said, individual perceptions about susceptibility to a disease, or the patient should perceive the severity of the disease. And there are a number of processes in B2 that can modify such a behavior, including socio-demographic characteristics, psychological factors, perceived threat of disease, and like, for example, a number of awareness campaigns may have such an influence. To have an awareness about a disease, there are a number of channels, there are a number of platforms. So this can have also an influence on the person's awareness about that disease. So the second stage is taking action. That's the perceived benefits of taking preventive therapy, for example, or taking some non-pharmacological actions like exercise, lifestyle, changing his or her lifestyle, maybe taking vegetables or consuming less carbon diets, like that. So this is the health model. The theory of reasoned action proposes that voluntary behavior is directed by one's intention to perform the behavior. Intention is a function of attitude and subjective norms. Here, there is an additional thing, subjective norms. For example, the attitude thing is the same. It's like before. The subjective norms in the theory of reasoned action is that our action can also be influenced by our neighbors, our peers, for example, our social environment. So this has also an action on our behavioral change. This is a detailed example for the theory of reasoned action, taking the example of HIV/AIDS program. For example, the person's attitude, for example, the young man is afraid of getting HIV/AIDS and believes that wearing condoms is good for protection. But the social norms, for example, that individual may have heard that taking, using condoms is not a cool one. It's not a cool action for sexual drive. So this is social norm. So there's kind of, balancing the decisions here, because one thing, he knows that using condoms is good for his health, but there's a social norm that using condoms is not cool just for sexual drive. So there's a kind of ambivalence here. There's ambivalence with using and not using. So it's about taking some reasoned action here. Trans-theoretical model. Anyways, the main part of this talk is not about teaching you the health models, but to show that there are a number of models which are very important to elicit behavioral determinants to develop a behavior intervention. So the trans-theoretical model, it has this model have a number of stages for a behavior to be acted upon. It takes a holistic approach, and it provides a framework for a wide range of potential interventions by health promoters. So there are different stages. The first is pre-contemplation stage. Pre-contemplation stage means that at this stage, the person has not considered any action because he is not aware of any risks. He or she don't know about any risks about his life or his health. At this stage, he don't know anything about for example, let's take for example, Ebola case in Australia. So nobody will expect Ebola is available here. So we don't know anything about Ebola virus. So we don't take any action. Yeah, we don't take any action at this stage. But if there's some case of Ebola virus found in Australia, for example, there is what? There is awareness among the community, among the friends, the media, something like that. So at this stage, the next stage is contemplation stage. Contemplation stage is that people may aware that there's some risk of getting Ebola virus. So they will try to understand themselves that there is a risk for getting the disease. That's the contemplation stage. Contemplation stage is just it's a stage at which you are aware of to make some behavioral change. Commitment stage, at this stage, you will outweigh the benefits of taking, for example, some preventive therapy, some immunization, for example, if there is for Ebola, versus not taking. So you will outweigh whether taking a vaccine is important. Maybe the good example is COVID vaccine, by the way, for this one. Whether you have to take vaccine for COVID or not. So it's up to you to judge or to evaluate at this stage whether I have to take COVID vaccine or not. Action stage, it's a stage at which you will take action. Maintenance stage, the new behavior is sustained and the person moves into healthier life. Relapse stage. Can you give me some examples of some relapse stage in this stage, in the trans-theoretical model? for this one, the best example may be, some weight loss interventions. Some weight loss interventions may result in weight loss for 5 months, for example, because of continuous exercise and continuous diet control. But the individual may hold or may stop exercising, may stop healthy dieting, then it will come to the previous his previous behavior. That means the weight loss will come again, so that it will come to high BMI, for example. So that's a relapse stage. If there is not any sustained health behavior intervention, it may come to a relapse stage. So these are some examples taking HIV/AIDS through this the trust theoretical model. Okay, stuck. Okay, can you give me some examples in which patient behavior can impact health? How many minutes do you want to take as a break? I'm not sure at what time shall we take some break of maybe 5 minutes. How do you progress so far? Are you taking a break or you continue for 1 and something hours?
Yeah, it's okay. Take a break.
Continue. What else? Do you have any other preference? I mean, yeah, okay. Actually, I'm sure we'll finish it in 1 and 30 minutes, I guess. Yeah, so yeah, it will not take 2 hours anyways. Otherwise, 2 hours lecture is too much without a break. Okay.
Sorry, Mister. I have a question about
Okay, good.
change before. Yeah, sorry. I want to tell you and others about my experience about that as health workers. Okay.
Okay.
If you tell before that about attitudes and belief action that can improve behavior change behavior, but what about many people start change when they feel the illness, but there are still many who don't believe it, even though they have seen many cases in their community. This is what happened in my neighborhood during the initial pandemic. I work in hospital, so I saw it in real. When I educated my friend, but they think it's not important. That they think it's not emergency like that. Until finally I get involved in any debate. I'm fighting. I'm fighting in a group or in a WhatsApp group, and I meet with my friend in some groups. And we debate, and the bad one is I said that just wait until the people close to you get the COVID.
Yeah, exactly.
It's kind of disrespectful word. I know it's not this bad word, but it's very difficult to educate people who don't have beliefs about that. What do you think about that, Mister?
Yep. Yeah. Still. Yep. I understand these situations. Yes. A number of factors come into play when we talk about behavior change. Yeah, there are some people who change their behavior because they experience some disease. For example, you may an individual may not take action until he have some disease. You know, for example, until he developed a cardiovascular disease, he will not take any action. This happens. It's for many anyways. And there are some social norms in the environment. For example, you know, when I compare Australian way of living with my country, Ethiopia, it's different. Here it's a culture, you know, exercising, dieting, it's almost a culture. Whereas back home, it's different. People don't worry about exercising, some dieting. They eat what they have. They don't want to choose. Actually, that depends on the socioeconomic status, social background, economic background, a number of factors. The other thing is, even within a single city, it may be influenced by your peer pressure, your family, apart from your internal belief. So that's why behavioral interventions are usually the most difficult to target, because a number of factors can influence a person's behavior. That's why we use models, because these models, when you talk about models, we will apply these models in some group of people so that we can have at least commonality factors or determinants that can influence a behavior, so that we can develop a tailored intervention for some group of or some subset of people. For example, people with diabetes may have a different needs, for example, to act upon some behavior. People with cardiovascular may be different, or some normal individuals different. So there is not any single answer for this one, because it depends on a number of factors, and individuals act differently. If I answered your question. Thank you for bringing the next question anyways.
Thank you, Mr.
All right. So patient behavior on health, as far as our, you know, I'm trying to bring, you know, behavioral issues with pharmacist roles. So I'm coming to our area, because the one we discussed so far is about behavior, patient behavior in general. Now, patient behavior, yeah, as I've said, behavior is an important determinant for health, and behavior by itself is influenced by a number of factors. So because of patient behavior, we do have a number of health problems as well. One is medication inadherence. That's why a number of questions have been raised regarding to non-adherence, because I was trying to bring the topic into pharmacy. Unhealthy lifestyle, that's because of patient's behavior. It's patient's behavior. Low vaccination rate, COVID-19 as an example, for example. So these are some examples of patient behavior on health. So let's take medication inadherence as an example, and I will go directly to digital health, the impact of digital health in influencing patient behavior, and then pharmacist role in digital health in connection with patient behavior. So adherence in general means that it's the extent to which a person's behavior is in line with an agreed recommendations from a healthcare provider. So the behavior may be taking a medicine, maybe a diet, or some healthy lifestyle. So if adherence is specific to medication, it is medication adherence. So the medication adherence we'll look at the timing, the dosage of frequency of taking the medicines during the prescribed length of time. So why medication adherence important? It's because it has a positive influence. It's a positive health impact. It reduces severity, or it reduces mortality, disease progression, increased quality of life. So these are some of the outcomes of medication adherence. But the main point here is that when we say that medication adherence, the first thing we have to look at is the medication the patient is taking is the right medication or not. You don't need to, you don't need to talk about medication adherence if the medication is not right. Yeah, does that sounds? I mean, if the medication is not right, you don't push the patient or the individual to be adherent. So the prescribing medication should be the right medication, and it should be taken as prescribed. So 50% of people with chronic conditions are non-adherent to their medication regimens at any given time. This is a big data, isn't it? It's a big 50% of people with chronic conditions are non-adherent. So the cost of medication in adherence, up to 25% of hospital and nursing home admissions are due to medication in adherence, specifically in patients with chronic medications. Actually, I mean in patients with chronic illness or chronic disease. It costs as high as 8.5 billion hospital costs annually. Actually, this is data from America, USA. So there are a number of risk factors for medication in adherence. So the medication, the risk factors may be occurred at the level of treatment, may be occurred at the level of patient himself or herself, at the level of healthcare system or providers, even from the disease perspective, and the social determinants, social factors, economic factors. This can also be reasons for medication in adherence. This is some of the 10 highest predictors for medication in adherence, including regimen complexity. That means too many regimens. If a patient is taking too many medicines and too many regimens, like from TID, 4ID, and have so many medicines, that's one of the reasons for medication in adherence. Side effects, treatment of asymptomatic disease. That means if the patient does not feel anything, but it was instructed to take a medicine. I remember people, for example, in my previous practice, people believe that once they have settled their symptoms, they want to stop their medicines because they believe that those medicines are acting like any medicine, like paracetamol. So this can be a reason for non-adherence. So anyways, these are the 10 high risk factors for non-adherence. One thing I wanted to link this one is with health literacy. Health literacy and medication adherence. Usually health literacy is related to the patient himself or herself here, the patient. For example, negative treatments, beliefs, poor insight into illness. Actually, this may be linked with health literacy, but other things, the one before here, patient health literacy is an important risk factor as well, specifically with people from immigrants or from low socioeconomic status, or people with some cognitive problems, or people with elderly people, actually. Such populations may have a problem with health literacy. So there's some link between health literacy and medication adherence as well. Health literacy means that it's the degree to which individuals have the capacity to obtain, process, and understand basic health information and services needed to make appropriate health decisions. So high-risk groups, can you name some high-risk groups for this one? Can you name some high-risk groups? Some examples of people having low literacy, low health literacy. Be free to talk.
In the rural area, maybe?
Yeah, rural area, yes, sure. Any more? Yeah, let's see this data. Low literacy is usually common in Blacks and Hispanics. This is American data, actually. Low literacy is highest in immigrants, specifically who complete only primary education. This is the one higher. The other is education level, the primary education level. With when you come to ethnicity, Blacks and Hispanics have lower literacy level, elderly people. So these are, yeah, others may be like, as I've said, rural, yeah, people from rural side, poor people or people with lower socioeconomic status, even people from, yeah, even people from prison. Okay, low literacy and medication use is related, as I've said. For example, low literacy means that there's a decrease in ability to identify their own medicines. It's 12 up to 18 greater odds of decreased ability to identify their own medicines. So this is a great number. You know, people with low literacy have a decreased ability to identify their own medicines. A decreased understanding of how to take the medications itself, and increased misinterpretation of common warning labels. These are some linkages between low literacy and medicines use. Health experience. So low literate patients commonly, sorry, my laptop freeze. Okay, low literacy patients commonly hide their difficulty. Why they hide their difficulty? Do you have some experience of, for example, assessing the patient's satisfaction in terms of getting some health service? Have you assessed, or have you checked if you encounter? How many of you have done some pharmacy services? Have you done? Have you done before? Do your patients measure patient satisfaction in terms of the health service they need, they access, or they get, or with the quality of the service? For example, I do have a study that I was trying to find out whether patient satisfaction is related to the quality of care or accessibility of services. So if a patient if a patient is have low literacy, definitely he or she measures patient satisfaction in terms of accessibility of services. He or she don't worry about quality. They try to look at accessibility of services. They look at efficiency of services. These are the measures usually, considered by low literate patients. But if a patient is high literate, definitely he will look at what kinds of service he gets, what quality, how strong the communication it was. It's not about accessing only, but they also worry about the information. Because they are avoidant, these people avoid behaviors. They're avoidance because they don't have any know-how about the disease, the medicine. So a number of issues have as a deficit. Okay. Do you have any experience, maybe as a brainstorming? Okay. Then assessing adherence. How do you assess adherence? Maybe this is a simple question, I guess. How do you assess adherence, medication adherence? A simple question, huh? Yeah, there are a number of tools. There are a number of tools for assessment of medication adherence, including objective and subjective. Patient interview, patient diary, adherence questionnaire, pill count, maybe. As it goes up, the accuracy increases. Prescription record review, electronic monitoring, maybe directed observed therapy. The most accurate objective is drug body fluid measurement itself, drug or biomarker taking, but this is very expensive one. So how we address medication inadherence? One thing is education. Another is motivational interviewing, addressing specific barriers, making taking medication a habit. These are some of the strategies important for addressing medication inadherence. Education may be about the indication, for example. It depends on the person's, the person's in focus, because sometimes the patient may not may have a problem in knowing the reasons for taking the medication. If that's the case, you will educate the patient about the indication, or else it's about the expectation, what the patient may expect. For example, it's common that a patient, prescribed for chronic illness, he or she may believe that he may stop after 3 weeks or 4 weeks, like any antibiotics. So he or may not expect that the medication may be taken for a longer time. So in that way, he may educate the patient that that's a chronic medication. Safety, just telling the side effect, and adherence aids me. Adherence aids like memory aids, about cost, maybe, or just about alternative medicine. Maybe you can talk about alternative medicines if the cost is a matter. And specific barriers for that specific patient, you can also address. So interventions can be educational interventions or behavioral interventions that can be directed at the treatment level, maybe directed at the patient level, maybe directed at the healthcare system, at the disease level, or socio-economic or social determinant level. So a number of things can be considered in tailoring interventions to particular people with non-adherence problems. What are you doing if a patient comes with non-adherence? What's your experience? What are you doing if a patient comes with some non-adherence decisions?
Give,
Sorry?
giving reminders or education.
Reminder. Yep. Reminders one. Yep, is right. Another?
Maybe we can ask why patient non-adherence. Maybe there's something problem. Maybe they can nyaman. Maybe patient can remember or many time medication in use patient, maybe three time in days or 4 time in days. Maybe it can being confused patient. The patient are taking medicine or not. Maybe that.
Yep. That means just you can, for example, have a number of medicines which mix it together and difficult to differentiate one from the other, so that you can separate the package like that. So yeah, that can be one point. Yes, that's also one thing. Okay, so anyways, there are a number of approaches to target medication adherence. Whatever educational or behavioral interventions is possible. So this shows that we can have a number of approaches to target medication and adherence, but it should be tailored because every individual is different, and the intervention also depends on the responsible risk factor or the responsible factor that resulted in medication and adherence. So let's come to digital health. This is a second section. So digital health, according to the International Pharmacy Federation, is saying that it's the use of information and communication technology to help improve human health, healthcare service, and wellness. So it's about use of information and information technology together for improving health in general. So, at this time, close to 4.5 billion people around the world are active internet users. So internet is almost in everyone's household. So and a number of smartphone users are there. That's close to almost surpass 3 billion. This means that there is an opportunity for people to use information and information technologies, including health apps, for the purpose of health. So this is very important issues for our health, that's digital health. So can you mention some of the digital technologies we have currently? examples of health technologies important for health includes electronic health record. Do Indonesia have electronic health record or not? Do you have electronic health record?
Ongoing.
Ongoing. So hospitals still didn't adopt electronic health record.
Yeah, no, but the government is now have a policy to using the electronic medical record from this year until 2023.
Okay, that's great. Okay, that's actually system-wide, government-wide digital health adoption, but still people have connection with smartphones, a lot of health apps. So still our health, our health-seeking behavior is affected by the mobiles we have at hand. With still we are affected by digital health. So at the system level, it may have some lack in adoption, but people have an opportunity to know about their health, to use their mobile apps for impacting their behavior, might be. So anyways, we'll come that one later. So we do have anyways a number of digital technologies for improving health, including electronic health record, e-prescribing and e-dispensing. That's electronic prescribing and electronic dispensing. Online pharmacy, telepharmacy, wearable technologies, and mobile apps. Wearable technologies is like a smartwatch. They are like a smartwatch, but they are storing our health data as well. They have sensors that can enable to store data. Specifically, these are very important for research purposes these days. For research purpose, I hope they will also come for normal use, for commercial use as well. I hope it will come soon, but they are now almost in for the purpose of research. And mobile apps. So, as we know, the COVID-19 catalyzed digital transformation because of the restrictions, social restrictions, closures, and people don't move from house to somewhere else. So that helps to facilitate the digital transformation. So these days it's common to have virtual visits. It's common to have virtual care. It's common to see remote patient monitoring, websites and chatbots for assessing a risk. So yeah, the COVID-19 has made a number of changes in the way our healthcare is delivered. So digital health interventions may target different audiences. The clients may target healthcare providers, may target at the level of health system, may target data just for for accessing data. There are some infrastructures built for the purpose of data, even for the purpose of data, because data itself is one way to improve our health. So electronic medical record and electronic health record. When we say electronic medical record, it's within a single organization, whereas electronic health record, it may be cross from organization to organization. Organization to organizations communicate each other through the electronic health record. So it will allow seamless utilizations of providers for patients. That means if there is one hospital in one area and another hospital in another area, the two communicate each other through electronic health record. But when we say electronic medical record, it's usually for that hospital, for a single hospital. So this has a number of benefits anyways, having electronic health record across a number of hospitals connected together have a number of benefits, including knowing that there's some kind of detecting some red case in in a hospital setting. Improved care for chronic disease, because there's some continuity of care, there's some connection. They know that if before it's difficult to get patient data from, accessing patient data from a paperwork is very hard, but through electronic health record, it's possible to easily access what the patient was doing for the past 1 year, in the past 5 years, in the past 10 years. All the history in the documents, easily accessible. So these kinds of things can have a number of benefits for us. Personal health records. What do you think this differs from electronic health records? Have you heard of personal health records?
Maybe it's like application in mobile, like now it's in Apple or Android. They can report our
Yep.
health in a
Yep.
day, and they record in application, so we can that
Yep.
in application how many hours we have sleep, what about our blood pressure.
Yep. Yep.
Just only on a watch.
Yep.
Yeah,
Yep. Yep. Okay. Yep. All these things can be. Let's differentiate personal health records and mobile apps or health apps. Yes, that can be also personal. Yes, it's personal, of course. When we talk about personal health records, usually it's system-wide adoption. It's government-wide adoption, and it's employed by every individual, but it's managed by the individual. Government will give access to those records, but it will be managed by the person himself or herself. So there's some connection. Usually this is, it's centrally organized and have some links with Medicare or Medicaid in America, so that people, the government knows what kinds of the medication the patient is taking, if actually the individual shared the information to the government, or if there's some kind of insurance issues, for example, because usually, Medicare may not cover everything. Medicare in Australia may not cover everything. So you may have some private insurance, or else just take some private insurance. So if in that case, you will share that information to your private insurer to cover that cost. So these personal health records are usually adopted by government, but managed by the individual. My health record in Australia is an example of personal health records. So everything is available here. The personal health record, in the personal health record, everything is available, even information not available in the electronic medical record, because electronic medical record it's for a single hospital. It does not show you what kind of information is available in another setting, because a single person may visit a number of healthcare settings, may visit family practice, may visit hospital, may visit dentist. So all this together can be found in personal health records, but not in electronic health record. So this is very good approach used by governments like Australia. I know Sweden is also have the same system. America have also the same system. I'm not sure about Canada, but such systems are very important.
I'm sorry, sir, I have a question.
Okay.
If a medical health record, they get the data from hospital maybe or clinic like that. So where's the personal health record? The people get the data about the health in private laboratorium or maybe, or what?
Look, this personal health records. It's government owned. It's imbued in the government file. That means you do have. Let me explain. There's my government documents in your name. You do have my government documents. In your my government documents, you do have a number of files. For example, your tax file, your current residency, your Medicare data, your tax, your salary even, your salary, your health record. Your health record is personal in that my government file. So that means that's central. It's centrally, and if you share to your GP, he can access it. If you share that document to a dentist, he can access it. If you share it to some other healthcare professional or hospital to hospital, he can share it. I mean, he or she can access it. So whenever a healthcare professional have access to that document, all the decisions will be there. All the decisions about the patient will be there, including the medical the information available in a hospital. So it's more of centrally, and it's the patient have the control. The patient have the control on that data. So it's up to the patient to decide the record should be given to a dentist or a GP or something like that. So it's more of personal control. It's personal control. But here, there's no that much detailed, specific disease-oriented medication medical history. No, just kind of general thing. The medicines are available actually. General disease conditions are available. What kinds of tests have been done is available, but not specific test results. No specific tests. It does not show, I mean, any variables which help guide decision. No, just general information. With this, it's general information with personal health records. M-Health applications. This is the one you talked before. Yeah, these are the one available in everyone's phone. M-Health applications. Because of the fast growing of apps, nowadays it's common to see people are using these apps for their health. So in 2017 alone, we do have 325,000 health applications worldwide. Before 5 years ago, that means nowadays maybe 500,000, maybe, I'm not sure. So this much health apps are available. So the good part about these apps, like the personal health record, you will manage your own health through these apps. You can manage your own health. Increase in evidence that health apps could have a positive impact on diet monitoring, physical activity, or medication adherence. And it's also possible to share, your data, your health data via mobile apps. Medication alerts using mobile phones is also possible. So this is one important aspect of interventions using mobile health apps for improving medication adherence. E-prescribing is also for repeat prescriptions for refilling, usually via mobile phones is also possible. Telemonitoring to transmit patient results to clinicians. Transmission both ways, from the patient to healthcare professionals or from healthcare professionals to the patient. So both ways can be possible. Booking is common thing. Appointment booking through apps is common thing. Efficient workflow through wireless communication. These are some of mobile health applications for medication adherence. I think you know some of the apps like MedSafe, DoxyCast, MedHelper, MyPillbox. These are very common apps for medication adherence. So this can be used by people who use chronic medicines usually. So what are digital pharmacists? Digital pharmacists are the ones who use digital health for improving health. So, but before before talking about digital health, let's see the pharmacy revolution in the last few centuries. Yeah, you know, pharmacy comes through a number of steps to reach to today. Today we do have an expanded scope of practice, and pharmacists do pharmaceutical care, clinical pharmacy in the ward, in the hospital setting, and now we are at the age of health information technology that brings digital pharmacists to the health service. So digital pharmacists are pharmacists who are doing or performing clinical services through digital health technology. These are some of the expanded health services. These are immunizations, CVD risk screening, point of care testing, patient counseling. These are some of the expanded care services. Plus to this, digital pharmacy is another area we can look at for the current pharmacy arena. Do pharmacists do immunizations in Indonesia? Do pharmacists work as immunizers? No immunization? Pharmacists as immunizers. Okay, what about cardiovascular risk screening? No? Okay, good. And let's go to next. So these are some of the expanded roles of pharmacists. So the use of digital technologies in pharmacy practice increased after the beginning of the COVID-19 pandemic. Yeah, the COVID-19 pandemic has transformed the digital technology so that pharmacy practice also follows this trend. There is a need to leverage the momentum of this digitalization and the need for solidarity among mental care professionals, including pharmacists, in harnessing the use of technology for digital health. Pharmacists are the first healthcare providers to adopt information technology for optimizing pharmaceutical care services. Digital technologies and distant care like remote monitoring, remote patient monitoring, become embedded more than ever in our everyday life with healthcare roles. So with this distant care, it may be, you know, pharmacists can give health education, may manage chronic diseases, or can do even medication reviews, distant medication review. For example, Australia pharmacists are taking different roles in patient care through telehealth, like med checks, diabetes med checks, home medicine reviews, residential medication management reviews. Yeah, this is are some of the role of Australia pharmacists through telehealth. Wearable data integration in decision making. This one, as I've said, it's like smartwatches who have sensors, you know, for health data. They will, you know, they will collect data about the person's health. For example, ECG applications that can support pharmacists in assessing the efficacy and safety of cardiac treatment. These are still in trial stage. In many of the settings, they're in trial stage. Health apps Yeah, with mobile environment of the patient is going to be the center of care. Yeah, if with the use of mobile apps, the patient can have personal control. So here, if you can have a role in their self-management or self-care. In their they can manage, they can involve in their self-care. So that means whenever there's self-care, there is behavior, because without behavior role, you can't have some self-management, self-care. So behavior have an important thing here. There's an important part. What's the limitations in digital pharmacist role in patient care? What's the limitations? What problems digital pharmacists encountered while delivering patient care using digital technologies?
The infrastructure, maybe.
Okay, yeah, right. Any other?
The regulation from government, maybe.
Yep, regulation in some areas. Yeah, privacy, confidentiality, adoption. Yeah, a number of factors. Yep, that's one thing. Another limitation.
The barriers from the health worker, maybe, that already used to the manually and transition to the digital. It's difficult transition to doing digital, like a digital, if not have a good literary about digital.
Yep, that's the digital illiteracy. Digital illiteracy is not only to patients but also to pharmacists. So that's one thing, because sometimes people who used to work in a paper may difficult to accept the working on digital things. So that's one thing. So digital illiteracy in general, may be one of the barrier. So yeah, digital literacy is in both ways, whether in pharmacists or in patients, because patients to access the health apps and installing, manipulating the health apps is also needs some digital skill. The other is unknown cost effectiveness because of a number of available apps, because usually apps may be released without passing through the cost effectiveness stage or some trial stage. So in that way, you don't know how much impactful the health app. You don't know. So adoption may be a problem. Cost of implementing e-health solutions usually is really costly. It's really costly. Internet access, specifically in areas where there's poor internet connection or no internet availability, that's a problem. Legal guidelines on privacy, that's the thing. Privacy, confidentiality may be a problem. Change management may not consider. Yeah, managers or health service managers may not consider digital solutions as part of innovative ways to health service delivery. So that's also another factor. So this is all about I have for today, and I don't have any assignment actually, but it was fine if I prepared some assignment for you. But I was told that I don't need to prepare assignment because it's not my role to evaluate you. I guess I was told that you don't need to prepare some exams or some assignments. Just come with some slides for this course. That was I was told. So if you have any questions, you are welcome. We do have 5 minutes. So how are you going to be evaluated if I am not evaluating you? I'm not sure, because do you take exams from these slides, or what was the intention? I'll talk to Andy about this.
I have one question, sir.
Okay,
Go back to about adherence. About behave about this one. Two strategy to change the behavior. Yeah.
This one?
Yeah.
This one?
No, the green and the gray. Yeah.
Okay.
Educational and behavioral intervention. Yeah.
Yep.
Can the reminding or giving warning improve adherence on taking medication effectively? Because I have a simple project using the simple electronic system using an SMS gateway.
Yep.
Yeah, like maybe like you have received a message like notification, maybe like a credit card payment that is past due. You have the message in phone. Yeah, so I have that project to warning the HE5 patient to go back to take the medication in the next month. So in 5 days before the drug is finished, they will get the notification 5 days. In 5 days. So it's effectively if warning by that one in reality. What do you think about that?
That's interesting. There's a number of studies that try to check whether SMS message can increase adherence. There are a number of studies. So yes, it's effective. In a number of studies, it mostly shows it's effective to send SMS reminders. Even it's common practice in Australia. You know, people always. I have received a number of messages. If I visit some family practice, or even with some vaccination, I usually remind it. Because it's an effective way. It's an effective way to increase vaccination uptake. It's an effective way to increase medication adherence. It's common practice. So yes, I believe on it, and it's a very important strategy. But it's also good to test it in your area, because it's different. You know, the way we adopt some intervention is different from place to place. Maybe in your area, SMS message may not be acted in the way we acted on. So that's good to test it, and it's effective. Yes, go ahead. Even you can persuade healthcare managers or service managers to embed SMS message into their healthcare record for the future, so that whenever they go to their home, they should be sent some notification before a week ago of their completion of their refill. So in such a way, yes, that's because this is the way we show the importance of our intervention.
Yeah,
so that's important.
It's especially for the rural area, because they not have a smartphone. They only have a mobile phone. They only get SMS.
Yeah. So that's multi-purpose. That's good. Designing in such a way, you know. Yes, I understand. not everybody have a smartphone. So I think that's well tailored for everybody. So that's a good thing. That's one important thing. So these days it's common to use SMS messages for research purpose, SMS messages for whether an individual is following the advice or not, even with some non-pharmacological interventions like lifestyle change, diet with exercise. Yeah, even there are such approaches in healthcare. So I think that's a good thing to begin with, to have behavioral interventions based on SMS message in MA Health. So that's important. Good.
Thank you for sharing.
No worries. Maybe another approach, maybe in the future, you can also use motivational interviewing. Motivational interviewing may also have an impact, but you can discuss. I mean, you can explore if you have some research interest on this area. Maybe checking whether motivational interviewing have an influence on medication adherence or not, or reminders, some other reminders, you know, or packaging, counseling, or some educational materials in addition to behavioral interventions, maybe some educational materials, maybe. So you can adopt a number of strategies. Okay, what else do we have? So this is all about for today, and it's great to have you here, and thank you so much for your time and for listening. I hope we'll have some time in the future for another coursework, if there is actually. I'm not sure.
Thank you, sir.
Thank you so much. Is Andy here or not? Andy's watching football.
Yeah, Dr. Andy not here actually. Thank you very much, Dr. Alex.
Okay, no problem. Okay, have a nice time, and bye, everybody. Thank you so much. Bye bye.
Till we meet again on
Okay,
next
no problem. Thank you.
Thursday.